All right, thank you. My name is Jonathan Lee. I'm a plastic surgeon here at Baystate, and this is Dr. Plosky. Dr. Plosky is one of our ENT surgeons. He did his undergraduate at Cornell University, and then he went on to graduate from Rutgers in Newark with a medical degree. He then did his otolaryngology and head and neck surgery residency at Yale University in New Haven, and he has since become board certified in that specialty as well as a fellow of the American College of Surgeons. He has an interest, obviously, in sleep apnea surgery and provides a variety of surgical procedures, including Inspire implantation, as well as oral pharyngeal surgery, including septoplasty and other nasal surgeries, as well as UPPP, invasive tongue reduction.
Thank you so much, Dr. Lee. I'd like to take a moment to introduce Dr. Lee now. He attended his undergraduate degree from MIT in Boston. He then went on to medical school at Mount Sinai in New York City and then stayed there to complete his residency in plastic surgery there. He moved across to University of Pittsburgh Medical Center to complete a craniofacial fellowship, went on to be board certified in plastic and reconstructive surgery, and he moved to Springfield and has been practicing here at the Baystate system since 2017. He offers a variety of treatments for sleep apnea as well, including the Inspire device with me, as well as a variety of nasal surgeries and skeletal surgery.
All right, thank you. So moving forward into today's talk, we have no financial disclosures at this point. And in terms of the outline of this talk, we're going to go through first defining obstructive sleep apnea, although most of you are pretty familiar with it. Then talk about the different types of surgery that are available that we perform that we may potentially be able to categorize you into. And that includes nasal surgery, throat surgery, skeletal surgery, and then a relatively newer operation, stimulator surgery.
Next slide. Perfect. Sleep apnea is the intermittent airflow blockage during sleep. On the left side of the screen, we see a classic cycle that your bed partner is pretty well aware of when they hear and see you stop breathing every night and with every nap you take. It starts with a snore, it leads to sleep apnea, holding of the breath, which then turns into low oxygen levels. And as you follow the circle around, your carbon dioxide levels go up. This leads to increased effort to take a breath, and then it arouses you enough that you actually move, you reposition, and then you repeat the cycle. You go back into it, you stop breathing again, oxygen levels go down, and so forth. On the right side of the screen, we can see with the levels of collapse in your upper airway. The orientation, you can see your chin on the left, the nose on the right, and sort of the opening of the mouth towards the mid top of the screen there. When you're collapsing, it could be from multiple levels, either in the very back part of the nose, or even the back part of the tongue, or into the pharynx area. Next slide. Every night when you're taking your sleep, if you have sleep apnea, you're losing more than just a good night's rest. You're really struggling. You're putting stress on the body. Every night you're getting decreased oxygen levels, which then puts strain on your heart, puts strain on your brain, and this leads to long-term stress on your body. Oftentimes, your primary care doctors find that your blood pressure is more difficult to manage, diabetes can develop and become challenging, heart disease, stroke, and even sudden death. Not just that, but during the day when you're in a fog, when you're often feeling fatigue, you're at increased risk for motor vehicle accidents, which is obviously pretty dangerous and leads to significant morbidity. Insurance companies know this. They've actually put a price tag. They figured out somewhere in the neighborhood of $200,000 worth of savings if they can get you to get your sleep apnea under control. So it's definitely a value for them to encourage you to get the best treatment possible. And we hope we can help you understand that and what your options are. Next slide. Here we see a variety of different findings and risk factors that help alert us to the possibility that you may have sleep apnea. There's non-structural things that we can't actually operate to fix on the left side, and then things that we actually can address with surgeries. Sometimes your primary care doctors, just by doing an exam, having you open up and say, take a look inside and see large tonsils. Obviously, these are things we can help with. But there's a variety of things that you have some control over too: alcohol consumption, weight to some degree, and then the rest of it, hopefully we can offer surgical options where it's available. Next slide. Once it's suspected, a sleep study often can confirm and give us an idea of how severe it is. Most of the evidence today that has most of the audience today that has already had a sleep study, you're well aware of the amount of hardware that's used to collect the data to help diagnose the sleep apnea. Today, we're focusing on patients who have moderate to severe degree of sleep apnea, as these are the patients who most of the surgical options are indicated for. Next slide.
All right, so now we're going to talk about how do we get you from that initial diagnosis to potentially an operation. So most people who have obstructive sleep apnea symptoms, they will move on to get a sleep study. And that sleep study will sort of determine your severity, which Dr. Plosky has talked about before. Generally speaking, people with moderate to severe sleep apnea will be heading down towards CPAP, which many of you may already have, versus some alternative therapies, including bite guards and other things that may be used to alleviate that. Patients who don't do well from CPAP, whether they fail it and it doesn't help them or they can't tolerate it, those are the candidates that we're looking at for potential surgery. Okay, and this pathway can have a lot of different perspectives in terms of surgery. This is a pathway that we are using in our institution, working with Dr. Plosky, myself, as well as our sleep medicine team. And ultimately, it comes down to potentially 4 different types of surgery, which we will talk about next. But how do we really decide which one is the most appropriate? And that's sort of what our consultation would be focused on. And a lot of that approach is determining where the problem is specifically. If you have obstruction in your nose and that seems to be the primary problem, then maybe a nasal surgery is appropriate for you. Versus if you have very large tonsils or adenoids, as Dr. Plosky was mentioning earlier, potentially a throat surgery may be better aligned. Or potentially you have a very small chin and a really pushed back lower jaw or even upper jaw, or maybe both. And therefore a skeletal surgery may be appropriate. And then we talk about the collapse of muscle tone in the back of the throat and backward movements of the tongue. And potentially it may be a stimulator, or it may be a combination of these. So that's what we're going to dive into next. So let's first talk about nasal surgery. Nasal surgery is really including septorhinoplasty as well as turbinate reduction. So starting with a septorhinoplasty, really what that means is straightening out the nose. The nose can have a variety of different types of deviation. You can have a simple C deviation, as we see in this middle photograph, or something a lot more complicated like an S-shaped deviation. What that deviated septum does, if you can look at the worm's eye view on this patient, is that it can really lock off one of the nasal nostrils or the valves in the nose. You may also have just naturally very small nostrils, and that can allow the nostrils to collapse when you're taking a deep breath. It also, with a small opening, doesn't really allow the CPAP to be able to push as much air, and you may not be able to tolerate higher pressures of CPAP if you have some level of nasal obstruction. So the surgery for that, there's a variety of different ways of doing it that we can discuss further in consultation if needed be, but oftentimes straightening out the nose can help you breathe better and can sometimes make CPAP more tolerable. And we'll talk a little bit more about this later, but rarely will someone with moderate to severe sleep apnea after getting a septorhinoplasty be completely cured of their sleep apnea, but it's more likely that they'll be able to tolerate lower pressures of CPAP and have better success that way.
Additional structures in the nose, the nasal turbinates. These structures function to warm and moisten the air as it enters the nose and then into the upper airway. These structures can be affected by allergies, blood flow, and in general, when they're swollen or enlarged, they narrow the nose. Next slide. There are a few different techniques that we have to make the turbinates smaller or create scar tissue to shrink them down so they can permanently not swell up and block your nose. In general, the surgeries are often done under anesthesia. It takes less than 15 minutes. You're able to go home on the same day, and it improves your nasal airflow. So quality of life right there. Next slide. There is evidence that when they've looked at patients who've undergone treatments for sleep apnea focusing on nasal surgery, either septorhinoplasty or turbinate reduction or a combination of, and they do find that overall quality of life can improve by getting better airflow, as I mentioned. Potentially, tolerance of CPAP can be easier, as Dr. Lee was mentioning earlier. But in general, in my opinion, and in my experience with patients, surgery on the nose alone is not likely to cure moderate to severe sleep apnea. In some cases, it making even the snoring a little bit more notable as the airflow creates more turbulence as it flows through the respiratory tract. Next slide. Throat surgery. Next slide. Taking a look on the inside of the mouth every time you go in and you say, ah, and your doctors get the chance to take a look in there. We're hoping that the doctors get a good look at the size of the tonsil, the size of the tongue, the positioning of the sidewalls, and the soft palate and uvula. At least that's what I'm looking at when I'm looking in your mouth. These areas in particular can crowd and decrease the airflow. The surgery, it has a nice abbreviation, UPPP. It kind of rolls off the tongue when we say it, but it stands for uvula palatal pharyngoplasty. And in this surgery, we're addressing the blockage in the back part of the mouth in the oropharynx. Oftentimes, the long dangling uvula that lays on the back surface of the tongue, the tonsils that obstruct it from the side, or even the muscles of the soft palate that are collapsing in there. And this surgery is performed under anesthesia, of course. After the surgery, the patients are often expected to stay overnight, and it is not a comfortable surgery, to say the least. Most patients find it quite uncomfortable to experience it. After the surgery is completed, we're looking at a sleep study a few months later to reevaluate how the patients have responded to this surgery. And again, the surgery is reserved for moderate to severe sleep apnea. We need to select the right patients for it. And so when we look inside the mouth, the top row here, numbers 1, 2A, and 2B, represent typical good candidates who respond well to the UPPP. Unfortunately, patients who have an enlarged tongue, which is causing the obstruction, which is the lower level there, the 3 and 4, they often don't respond as well to the UPPP and often have significant residual sleep apnea disease. Also, patients who are morbidly obese, significantly overweight, tend not to do as well, or if there's a lot of collapse of other structures in the airway, they tend not to do as well. Next slide. In the right patients who receive the UPPP, I would hope to reduce their sleep apnea score, potentially cutting it in half. But that's on average. Usually we're able to get it lower, but maybe not all the way enough to get a full cure over time. Therefore, we need to follow these patients who may have some residual sleep apnea. Next slide.
Okay, so now moving on to skeletal surgery. In skeletal surgery, we're going to be talking mainly about maxillomandibular advancement, otherwise known as MMA. So the reason why you would consider skeletal surgery is because people with small jaws or chin can result in obstructive collapse of the airway. And as you can see, the patient in this diagram, the person on the left has a normal dental facial relationship. And you can see the blue is the stripe of airway. Now, compared to someone who has a significantly smaller lower jaw and chin, you can see that the tongue is pushed backwards, and that nice blue, now in this area it's red, it's showing a much decreased size in that airway and more likely to collapse. So the goal of the surgery is, in order to open this up, is to pull both the maxilla or the upper jaw and the mandible or the lower jaw forward. And we do that through an incision, both usually on the upper and the lower jaw, on the inside of the mouth. We are dissecting out the skeleton of the jaw of the upper and the lower, and we are making breaks in the bone using a bone saw, and we cut the upper jaw and the lower jaw, and that will allow us to move both structures forward about 1 centimeter. And then we plate the upper and the lower jaw with small screws and plates in order to hold it in position for the bones to heal. As you can imagine, this is quite an extensive operation. You're looking at about 6 to 7 hours of surgery, so pretty much all day, and at least a several-day stay in the hospital, potentially one of which in the intensive care unit. After discharge, you may potentially have your jaw wired together, which means that you'll be on a liquid diet for several weeks, potentially even up to 2 months. Weight loss is associated with the surgery just because of the diet changes, and it can take a couple of months for people to recover and get back to normal. This is one example of a patient who, similar to the prior photo, has a very small lower jaw and chin. And in this surgery, we use computer modeling. So we use virtual surgical planning to perform the surgery in virtual space. And then we are able to translate that into the operating room in order to perform the cuts and the movements in an expedited manner. And as you can see, she does have a significant change in her facial structures, and resulting ultimately in a great improvement in her obstructive sleep apnea. So looking at the research and the data for that, this is highly associated with good efficacy. Nearly all patients have some level of improvement. The amount of improvement, although can vary, generally speaking, the reduction in your AHI or the severity of your sleep apnea is reduced to 80% of its original. And cure rates can be very achievable for patients with a moderate to severe obstructive sleep apnea, although less than 60. So people with severe disease may not really get a cure rate, but still will get a significant improvement in their symptoms and sleep apnea. And as we talked about, because we are moving the skeletal base for your face, there will be some cosmetic changes that come with it. So I think in general, we're reserving this or looking at this in patients who have significant dental facial differences that could potentially benefit from this operation, both in terms of sleep apnea, as well as harmoniously balancing the structures of the face.
All right, let's take a look at the newest tool we have to treat sleep apnea. Next slide. The hypoglossal nerve is the superstar of this part of the story. It's the 12th cranial nerve. It comes out of the base of the brain. It controls the voluntary movement of the tongue. The path of this nerve as it exits the brain area goes under the jaw to the muscles of the tongue. Next slide. Here we see a nice schematic showing that nerve as it goes into the muscles. Again, the hypoglossal nerve is controlling the tongue movement as it moves out and back in. Out being the green direction, those particular muscle groups, and the red being the back in. Delicate part of the surgery is identifying this blue region in the middle. That's the break point where the nerve separates into the muscles that are moving it green-wise forward and red back. What we're going to be doing during the surgery is placing a very delicate cuff that has small electrodes that stimulate that nerve to send a signal into the muscles to make it move the way we want it to move. We want to stimulate the muscles that move it forward and avoid the muscles that pull the tongue back and block the airway. Next slide. Okay.
Right. So there are several different type of stimulators that are available both in this country as well as internationally. Inspire is the one that we're going to be talking about today. It has been FDA approved for implantation since April of 2014. Again, indicated for people with moderate to severe sleep apnea. The data collection is very similar to that seen in CPAP devices based on cloud technology. And there's a growing body of insurance companies that are starting to accept it, especially in Massachusetts. The other two that we see here, the Aurora 6000, is basically the same device as the Inspire. However, it does not have full FDA approval currently. It has been FDA approved as of June of 2021, only for clinical trial purposes. But in all essence, everything about it is extremely similar to the Inspire. The other device, the Genio, is slightly different. It is a device that does not require an internal battery source or leads that we'll talk about with the Inspire device, and is implanted on top of the muscles under the chin. The main thing to know about it, though, is that it is not FDA approved, even though it's approved in Europe. But I would avoid traveling abroad to get any of these devices put in, because when you return back to the States, if you're having any problems with them, there's really not going to be anyone to help troubleshoot that for you. So again, we're going to be talking about the Inspire device. As Dr. Plosky was mentioning, there is different components to this, and it's really three pieces: 2 leads and 1 generator, or the battery. So there's 2 incisions, 1 incision in the right upper chest, and that's where the battery or the generator is going to be placed. That's also where we're going to be placing a sensory lead that you can see here. And that sensory lead is going between the ribs, between the muscles within the ribs, to sense when pressure changes are happening in the lungs when you are sleeping. There is another lead that gets tunneled across the collarbone up into the neck around the portion of the hypoglossal nerve that Dr. Plosky was mentioning. So when you're sleeping at night, you turn on the device with a wireless remote, and there's a latency period to allow you to fall asleep, and then the device will start working. When the sensory lead senses pressure changes of you trying to inhale, it will then cause stimulation of the hypoglossal nerve to slightly stiffen and protrude the tongue. So this is the stimulation is timed with inspiration.
You'll be seeing either Dr. Lee or myself for screening to see if the Inspire device is appropriate for treating your sleep apnea. So in this part of the screening, we'll be seeing you in the office. It's important that we review your prior sleep study to confirm that you meet the criteria to get the device. This device is approved for moderate to severe disease with AHI, which is the index of the number of times that you're holding your breath per hour. We need to see a number between 15 to 65. Occasionally, patients come in with numbers outside that range, and this device just really is not for them at this time. Maybe in the future there'll be some updates, but for now we're really focusing on screening for the patients who are going to have the best success. Additionally, we want to make sure that you've tried CPAP, as we do feel strongly that CPAP is the gold standard for CPAP for sleep apnea treatment. But we also recognize that sometimes CPAP just isn't tolerated. So we always want to review what your experience has been with CPAP. And finally, it's appropriate to take a look at how each individual's airway is collapsing. And we do this with a drug-induced sleep endoscopy. Next slide. Here we see motion videos on the left side, candidates whose collapse will often be helped by the Inspire device. And in the middle of the screen, in the right side of the moving picture, we see a collapse that most likely will not be helped by the Inspire implantation. To get this performed, we want to mimic your natural sleep breathing cycle. So we take you to the operating room with no intention to make any cuts or any surgery that's irreversible. We just want to give you some anesthesia medications, let you fall asleep, and have your muscles mimic what it looks like when you're naturally falling asleep at home. The nerve stimulator has been found to really help the patients whose collapse is on the left. And so we want to see how each person is collapsing. The majority of people, by the way, do have the normal good candidate for this. And we want to just cycle out and find those patients who are collapsing in a fashion that won't be helped, which is a small minority. Next slide. Unfortunately, as I mentioned a moment ago, the implant is not right for everybody. Sometimes the pattern of sleep apnea prevents the device from activating. In particular, patients who have central sleep apnea. In this particular case, central sleep apnea represents patients who their chest movement doesn't trigger the sensor to activate the generator to move the muscles. And if that central sleep apnea is present to a significant degree, the machine will never activate and never really open the airway for you. Additionally, sometimes the muscles that are stimulated cannot open the airway enough from collapse. As I mentioned in the previous video, sometimes the collapse is coming from the sidewalls, which really isn't helped by just the tongue movement. Additionally, other factors like obesity are not able to be overcome by the implant. The implant is metallic, and so if you do have a requirement that you receive MRIs of the chest on a repeated way to image things, this might not be right for you either. Next slide.
Okay, so what happens after you get your implant? So 4 weeks of healing is required before we can activate the device. The activation of the device is done in the sleep medicine facilities. So seeing either Dr. Plosky or myself pre-surgery is usually 1 or 2 visits, and you then go on to have your surgery. The first post-operative visit is generally a week after, and you may have another post-operative visit at a month before activation, depending on how things are. So when things are activated for the following 1 to 2 months, you're then getting some levels of adjustments. You're checking in. There is, again, all the data is cloud-based, so you can check things through your phone, and the provider on the sleep medicine side can also do that. Now, at about 12 to 16 weeks after surgery, this is where we're really doing more of the titration to make sure that the levels of stimulation is being effective for you, and that can be modified either going up or down. And then that really will get you, once you're titrated, get you to that steady state. And at that point, you only need maybe 1 or 2 visits a year with the sleep medicine doctors to really make sure that you're turning the device on and sticking with it, and that there's really no issues. And we're also wanting to make sure that quality of life is improved, as well as making sure that you continue to be rid of and improve from the health complications from obstructive sleep apnea. So, to recap, it's not just putting the implant in and then the next day everything is normalized. We do have some time for you to heal, as well as time for us to ramp up the device and get it to a level that is going to be effective for you. So taking a look at the research for this device, this is really based out of the STAR trial, which is a 5-year follow-up trial throughout different institutions in the United States. And this has really shown some impressive results in the sense that you have a significant reduction in the apnea-hypopnea index is what we are looking at in terms of the severity of OSA. And you're having a significant improvement in this that stays for 5 years. And then also in terms of quality of life, you're looking at the sleepiness scale that your sleep medicine doctor will sometimes grade you on, and that's also demonstrating significant improvement at a 5-year period as well. Looking at a different registry, this is the ADHERE registry of over 1,000 patients that were collected. And again, looking at the results of the reduction in obstructive sleep apnea and that AHI index, you're seeing a significant amount of reduction in that by the from baseline to its final time point for these patients, as well as the same things we're seeing with the sleepiness scale. So overall, the data for this has been very impressive, to say the least. So, based upon that, that's a big reason why Dr. Plosky and I had collaborated to bring this device to the Pioneer Valley. This was a device that I was initially introduced to in Pittsburgh, which is one of the original sites where the Inspire was first developed at and trialed. I think it's something that has been a big game changer in our armamentarium for treating sleep apnea. So just kind of reviewing our pathway. You failed sleep apnea. Do you have problems breathing out of your nose? If you do, you may benefit at least partially from a nasal surgery to improve your ability to tolerate CPAP. However, most people don't necessarily have this problem, and then we move towards DICE, that drug-induced sleep endoscopy, where we determine your collapse pattern and your pharyngeal tone. At that point, if you have that AP collapse, that anterior-posterior collapse that we're looking for, then you're a good candidate for hypoglossal nerve stimulator and implantation. However, you are that concentric collapse patient, what do we do from there? Well, you have a couple of options. One is that Dr. Plosky can perform a UPPP for you, and sometimes, because that is removing tissue from the lateral side of the throat, that can convert you from that concentric collapse to a AP collapse. And if that anterior-posterior collapse is needed for the hypoglossal nerve stimulator, then you may be good if the UPPP does not fix it. Alternatively, if you don't want to necessarily go through that pathway, we can always do orthognathic surgery. Orthognathic surgery and Inspire can also be done interchangeably, such that if you're not improved with one or the other option is still available. And as I was saying earlier, orthognathic surgery, at least in my practice, I'm trying to really indicate that for people with significant dental facial differences, that is likely the main cause for their obstructive sleep apnea. Dr. Plosky, is there anything else you would like to add?
No, I think this was a great overview. I hope patients have a better idea that it's not a one-size-fits-all specifically for treatment of sleep apnea if they're failing and struggling with the CPAP. There's a lot of different directions and a lot of different ways we want to look at where they're having difficulty. And I think that diagram really shows nicely that we're looking from top to bottom in multiple ways and seeing how and where we can use surgery to help patients breathe better at night.
All right, well, thank you. Thank you for giving us the time to talk to everyone about this. And, we purposely left some time for us to answer any questions, and I'm sure people will have plenty of questions to ask.
Thank you both. That was a great presentation, and you're definitely a great team together. There are a couple of questions in the Q&A box. First of all, Sandy is asking, can you discuss any of the appliances that are not surgical other than CPAP?
Yeah, so I can talk a little bit about it, and Dr. Plosky can add to it. So, the main appliance that people have used, in my experience, are dental appliances that are basically used to protrude the lower jaw. So basically pushing the lower jaw forward, almost like you have an underbite. And what that does is, because the lower jaw is connected to the tongue, which is connected to the throat, it will help push things forward and open up the airway. So it's very similar to what we're doing both with the Inspire device, as well as what we would be doing with the skeletal surgery, in terms of moving the skeletal components forward, which then moves the tongue and the palate forward, since everything is all connected. That has had variable success. There's like stock options where it's sort of a one-size-fit-all scenario. However, there are orthodontists who will make a special custom device for you. I found that insurance companies will either cover CPAP or they cover that device, not necessarily both. So most people end up using CPAP because they find it to be a little bit more effective. Those dental appliances can sometimes also cause some TMJ, like TMJ joint pains, or changes in a person's bite if used for a long period of time. So there is no perfect answer for CPAP or for these devices, but it can be used.
Those devices are also, I'll typically have a discussion with patients about those devices when they have mild to low moderate disease. I don't think that they're very successful for severe disease, though. So AHI scores less than 20, probably suitable to consider that to help the airway stay open. But as for cure of severe disease, less likely. In some cases, it could be considered to use the mandible advancement device with a CPAP machine too. So, keeping the airway open, almost like it's splinted open, and then using the CPAP to help move the air through it.
Do you have, Dr. Plosky, do you have any experience with palatal lift devices?
Not so much experience with those devices.
Yeah.
A couple of years ago, we had somebody in our practice who was performing some of the stiffening implantation devices, but they haven't had the greatest success with those. So
Yeah. I agree with that.
Okay, we have quite a few more questions coming in both the chat and the Q&A. So thanks, Ken, for keeping those in for me. There was a question from Emily about reviewing this presentation at a later date, and it will be part of the Inspire article that is on baystatehealth.org, as well as the Baystate Health YouTube channel. So you'll be able to find that, as well as our loyalty program pages. For the next question, is there a battery in the external device? If so, how long does it last?
That's a good question. The internal device, the batteries tend to last about 10 years. We have not had to change one yet, as we're not at the 10-year point for the devices. The external device, that small handheld tool that's brought over the skin, yes, that has, I think, just a double or a AAA battery that goes in there to help give that power, and that can be, I don't know how long those last, but they're more readily available and much easier to change than the internal one.
Excellent. Yeah, I would say that the internal battery, because the whole thing is essentially a battery, is very similar to a pacemaker or any other sort of nerve stimulator. However, because it's not running 24/7, it's only being run at night or whenever you're sleeping, because you can turn it off and turn it on. The battery life for that tends to be a lot longer than similar devices which are running all the time. So 10 to 15 years, I think it can be reasonable depending on how often you're using it. And then also the surgery to exchange that is very simple. It's also ambulatory day-stay surgery, and probably half the amount of time that it takes to put the device in to swap out the battery. So,
Excellent. Thank you. Good to know. Next question. And as I said, there's quite a few coming in. I have an AHI of 5.4. Would I be a candidate for the Inspire?
No. With an AHI of 5.4, you're in the low mild category of sleep apnea. We would likely during a consultation be looking at alternative ways of helping you breathe better at night, perhaps addressing a nasal obstruction or encouraging you to pursue the mandible advancement device we were just talking about. In some situations, positional, looking at the positions you're sleeping in, various pillows and other options for getting you into a position where your airway remains a little bit more open on your side or your stomach. Potentially looking at weight loss, alcohol consumption, if you have enlarged tonsils, and potentially if you have significant symptoms of fatigue, even though you're in the mild category, still encouraging you to pursue CPAP if that was possible. But the Inspire device, as I mentioned earlier, it's really designed and effective for patients who have AHI scores between 15 to 65.
Thank you.
agreed. Yeah.
Linda would like to know, do either Dr. Lee or Dr. Plosky have any experience with adults with Down syndrome that have OSA?
Yeah, so I would say not necessarily adults. I've had some experience in fellowship in my training with pediatric patients with OSA, and oftentimes these patients are getting some variation of a UPPP earlier in life, and that sometimes helps, but not necessarily always. So Inspire is becoming a growing indication for these patients, and there is trials currently at children's hospitals. I believe Boston Children's has one specifically for Down syndrome patients, at least in the pediatric population, and obstructive sleep apnea with some promising results. Now, Down syndrome is complicated in the sense that there's both a muscle tone component as well as a skeletal component. Oftentimes, patients with Down syndrome have small upper and or lower jaw. So, potentially a skeletal surgery may help to some degree. However, as I said, it's a pretty intense operation. So I think it's very promising that hypoglossal nerve stimulator like Inspire is sort of broadening its indications into this group of individuals as well.
Thank you both. Stacy would like to know how many of the surgeries have been done specifically the Inspire device.
Do you mean at this institution or in general? Because there have been thousands internationally. It's actually much more popular in Europe, where it was initially developed. In our institution, this is something that Dr. Plosky and I have been collaborating and working on bringing here since I joined in 2017. We've had our first implantation December of 2019. However, things were put on a little bit of a hold due to the COVID pandemic. But we've been back up and running since December of 2020. And we've been implanting 2 to 3 patients a month since that time, and we're scheduled out several months in advance. So this is definitely very popular, and we're looking forward to treating many more people with this. Excellent.
Thank you. Jennifer would like to has a question. Hi, I have an appointment on 11/2 for a consult with Dr. Karen Johnson. She's a sleep specialist.
Yes.
So I was just interested in what procedures there are. I have an endoscopic sinus surgery and sinuplasty in the past for nasal polyps. I think this may be my issue with sleep, but not sure.
Sure. So you may have obstruction in the nasal passage if you have nasal polyp or regrowth. That's something that can be looked at in the office. But Dr. Johnson is part of our sleep center team, the sleep medicine doctors. Very likely that consultation may involve looking at a sleep study that you may have previously done or scheduling one to determine the severity of your sleep apnea. So that's it is possible that something like that would be causing your sleep apnea.
Thank you. Pamela asks, I have been using my CPAP for over a year now when I can tolerate it through the night. Maybe this might work for me. Much better? Maybe she needs a consultation.
Yeah, I would, we have our numbers on the screen. I still have my screen share on. So, you can call either office and just mention that you're interested in the Inspire device and you have sleep apnea, and you'll get funneled to the right pathway for consultation.
There's also an option in the survey to put in your information, and we can help you get a consultation with either of the doctors as well. Great information from Jennifer. She'd like to let you know. Kim asks, have you noted any success with devices that spread the mandible wider?
So there are devices that don't necessarily spread the mandible, but they will spread the maxilla. And
oh, I think that's what she meant. She's got the upper bone. Yes.
Yeah,
that's
yeah.
Right. She has an addendum to her question.
Those are palatal expanders, and that's more of an orthodontic component. And the thought behind that is that if you expand the palate, then you have more room for the tongue to be. So if you have more room for the tongue, it's less likely for it to get pushed back and potentially cause obstructive problems. I don't think the data for that, the research for that has been very good in the sense that it's showing high levels of evidence for that. I don't think it necessarily hurts to do, but oftentimes these procedures are, especially with orthodontics, they aren't really covered by insurance unless you have very good dental insurance. So it ends up being a lot of out-of-pocket cost. So, it is technically a non-surgical option. So if that's what you value, I don't think it hurts to try it. But at the same time, it may not be what's fixing the problem. It may help to some degree. But again, for someone with moderate to severe sleep apnea, I cannot say that that's a confident way of addressing it.
Thank you. Christine asks, with regard to Inspire, are you contraindicated for any MRIs after it's in place? You mentioned frequent chest MRIs.
So that's a good question. Chest MRI is definitely contraindicated because the device can be significantly damaged, or it can cause unwanted side effects locally in that area when you're in the MRI. That being said, the new devices that we are implanting now, the new generators, are approved for MRIs of the extremities, your legs and your arms, as well as the head. The old devices that were implanted, more than 3 or 4 years ago, those devices, you can't have any MRIs really at all. So the new devices that we're putting in now, you can at least have an MRI of the head or the extremities, just not the chest.
Thank you. Bill would like to know, to what extent does age factor into someone's opportunity for this procedure?
The lower limit, we on the screen earlier, we mentioned age 22. The upper limit, it's not as well defined. It's more relevant for tolerance for general anesthesia for a few hours and any comorbidities you have, as we sort of expect you to have hypertension potentially or diabetes. From sleep apnea, these are common comorbidities. So those are not reasons that you can't have it. But whether you wish to undergo it, if you're not tolerating the CPAP, we can of course discuss whether it's right for you and whether you're willing to undergo the anesthesia for it.
Agreed.
Thank you.
As long as you're healthy, I think there's no reason to not do it if you meet criteria.
Ryan would like you to know that he does well with CPAP. I'm overweight. I've been using my CPAP for well over 10 years. Diane, Linda, in regard to the person with the Down syndrome, she's asking, so would you suggest going to Boston for an evaluation for an adult with Down syndrome?
Potentially, they may be having more experience with that population of patients with that diagnosis. Obviously, Dr. Plosky and I are more than happy to evaluate you. I think Down syndrome within itself doesn't mean that you're not a candidate for it, but it does mean that there may be potentially other aspects that go along with it. Generally, Down syndrome patients have pretty severe obstructive sleep apnea and may require a series of surgery, as what Dr. Plosky and I were alluding to earlier. They may require UPPP first to lower the severity and to improve the collapse pattern, and then become a candidate for Inspire. So I think either Boston or us is completely okay. However, we're not really participating in any sort of at least pediatric trials for Down syndromes. So those patients that we get referred, I oftentimes would refer them out to the Boston Children's for that.
Thank you. Brian added to his last post, all I know is my numbers are very high, suffer from some nasal issues. I'd like a new option. So it sounds like he needs a consultation with either of you or both.
Happy to help.
Bill asks, is it possible to have a procedure if you have stents?
Cardiac stents, I'm assuming. And
Yes.
that is possible. It just depends on your dependence for the blood thinners that go along with the stents. This surgery does require dissection in the neck area, as well as in the chest area between the ribs. So, ideally someone who is needing to be on blood thinners and can't come off of it, that is sort of a soft contraindication. We'd be hesitant to take you to surgery for that because there could be significant complications afterwards related to bleeding. However, that's a conversation that we would need to have, as well as getting weigh-in from your cardiologist or your primary care doctor who is managing any sort of blood thinners for those stents.
Thank you for that. The next question, how does the history of allergies with postnasal dripping affect the use of a CPAP machine?
Allergies and a postnasal drip, depending on the amount of nasal drip you're experiencing. Sometimes patients feel that mucus and they get uncomfortable with the mask perhaps, but in general, many patients have allergies and very many patients tolerate CPAP. So I wouldn't say it's something that's always going to have difficulty, but each person's individual. And whatever you're experiencing, whether it be swelling from the turbinate area or interaction with swelling of the mucosa or a sinus infection, these things can all play a role in how you feel air movement and respond to the pressure sensations from the CPAP.
Thank you. Part of this question, I believe you've already answered, but how many Inspire, UPPP, and
Orthognathics.
agnic surgeries have been done at Baystate over the past few years? And they wanted you to know it's an excellent presentation.
Thank you very much. The number of UPPs has actually been decreasing in the recent few years. They're still performed. I performed probably about 2 per month over the past few years. And I'm in a group with 7 other ENT surgeons, and they're probably performing on average a few less over the course of a year, but they're still being performed.
Yeah, and in terms of orthognathic surgery or the skeletal surgery, that also has been decreasing over the years, primarily because of Inspire. And that surgery is performed by myself. It's also performed by an oral surgery group that I oftentimes partner with in the area. And in general, we're doing, maybe I would say maybe 2 or 3 cases a quarter. So not nearly as frequently as what Dr. Plosky was saying for UPPB. And that sort of makes sense considering the invasiveness for this. And again, I'm really reserving it for people with dental facial discrepancies and not necessarily somebody who has a normal facial anatomy, but has sleep apnea.
Excellent. I think we've been through all of the questions. If we could just give it couple more seconds here just to make sure if I've missed any, since there was quite a few that they could retype them in.
Dr. Lee, what advice do you often give during your consultation if patients come in who are not candidates secondary to significant obesity, or the severity of their sleep apnea puts them outside the range of the criteria for the Inspire device?
Yeah, that's a good question. I think for patients whose sleep apnea severity is beyond an AHI of 65, I oftentimes send them to you, Dr. Plosky, because they may benefit from a UPPP to reduce that and get them into a better position for us to do Inspire. I do talk to them about orthognathic surgery as well, but as I mentioned in the presentation, people with an AHI of greater than 60 oftentimes do not get a full cure. So even orthognathic surgery, they may still have a significant amount of obstructive sleep apnea present, which may further be reduced by either a UPPP or with Inspire. So I think those people with really high disease, you're going to need more than one surgery, likely. So it's just the question of the path of least resistance, which I think oftentimes will be a UPPP followed by Inspire. For the second part of your question, Dr. Plosky, with people with elevated body mass index, with severe obesity, I think it's really 2 problems, right? The obesity and the obstructive sleep apnea. Obviously, obesity can impact obstructive sleep apnea, but if you have moderate to severe disease, it's unlikely that normalizing your body mass index is going to completely get rid of your obstructive sleep apnea. So I think you're really talking about 2 separate problems, and the obesity, if it's that severe, that within itself is a significant health risk. And that, in my mind, takes a little more priority because if you can reduce the obesity, then you have more options for us to treat the obstructive sleep apnea. So trying to reduce that obesity is a priority for me, and that oftentimes may require nutritional consultation and potentially bariatric surgery to do a weight loss operation to get to that point. And as a plastic surgeon, we frequently work with the bariatric surgeons because after patients lose weight, they do have a lot of body contouring components that we are involved with from a plastic surgery standpoint. And I have definitely seen patients who have lost more than 100 pounds after bariatric surgery with significant improvements in their high blood pressure, diabetes, as well as their obstructive sleep apnea. So it is something that is sort of hand in hand with obstructive sleep apnea and reducing that body mass index.
Very true. I really think that sleep apnea is a multidisciplinary disease. It involves the sleep medicine specialists for the sleep studies and interpretation and the CPAP titrations. It involves the plastic surgery for evaluation of different anatomies, potentially nutrition, bariatric surgery, primary care to manage the underlying comorbidities that go along with it, my specialty, ENT. So I really think that this is a very encompassing condition, and it's a challenge. And we hope that we were able to give a good overview of the direction that sleep apnea surgery is going.
Thank you for that. There are a couple more questions if you want to take the time to briefly talk about those
Sure.
before we end. We could just take a couple more minutes.
Sure.
Bill, and maybe this is a segue into what you were just saying, but Bill asks, is the cause of someone's sleep apnea identified first before treatment is selected and recommended?
Oftentimes, the sleep study is going to help identify the severity, but potentially even the cause as it relates to central or obstructive. The exact level of obstruction would be better identified during the drug-induced sleep endoscopy or during the consultation where it's visualized where the obstruction's occurring. I hope that's helpful.
Thank you.
Yeah, I think we try our best to determine where the component of collapse is, but I would say the majority of people, it's not necessarily one specific site. It's that you just have insufficient muscle tone in the throat to keep it open during sleep. And every person will lose some amount of tone when they're sleeping, and that airway will collapse, but it won't necessarily collapse all the way. So I think at the end of the day, stimulator surgery can work for a lot of people with moderate to severe disease. And we're really using some of these other surgical options that we presented today as potential adjuncts for people who kind of fall outside the realm of normal. So I do think, Dr. Plosky, and I do think that this Inspire treatment option is going to potentially be the mainstay of sleep apnea surgery for the most part. And then obviously people who don't completely get benefit, or people who have very specific other areas of obstruction, we can then indicate them for other surgeries.
Excellent. Well, thank you both for your time and expertise for this great presentation and all the great answers to the questions for the audience. So thank you very much.
Thank you.
Thank you very much.